The PharmCast is a podcast sponsored by the Maryland Pharmacists Association. I'm your host, Aaliyah Horton. I'm the Executive Director of MPHA. And in my role, I have the opportunity to meet so many fascinating people within Maryland and around the country that are engaged in the practice of pharmacy. They're stakeholders, they're innovators, collaborators, and advocates. And this is my opportunity to bring those conversations and experiences to you. And it's another way that MPHA is fulfilling its mission to strengthen the profession of pharmacy, advocate for pharmacists, and to promote excellence in pharmacy practice. My hope is that at the end of these conversations, you will leave informed, engaged, and connected to pharmacy and our Maryland pharmacy community. Welcome to the podcast, the PharmCast. Today, our guest is Neil McGarvey. He is co-owner of the Professional Pharmacy Group, which includes Arnold, Annapolis, MedPark, and Empire Professional Pharmacies, and KCLTC Pharmacy. He's practiced pharmacy locally in Maryland for 20 years and is a proud graduate of the University of Maryland School of Pharmacy in Baltimore, where he received his PharmD. He enjoys being in the pharmacy daily with his staff and commiserating with members of the local Arnold community. And he also enjoys the challenges of medication compounding to suit individual patients' needs and teaching students about the profession of pharmacy. And one thing I will add is that when I was reading your bio about the commiserating with the members of the local Arnold pharmacy community, I did think of the late speaker, Mike Bush, who was very fond of you and the pharmacy. So
yeah, he's sorely missed.
Yes, he had a tremendous legacy. So welcome and thank you. And so
thanks for having me.
Yeah, of course. So one of the reasons there are many reasons why I want to talk to you. I do enjoy running into you because I do run into you a lot in just lots of different places. And for me, as the exec of MPHA, it's great to see pharmacists in different positions where policy is being discussed and where sort of action is taking place. And for me, I can see the people who are really engaged in the community and who are concerned about the practice of pharmacy. And even if the person may not be on a specific MPHA committee, I see you're working on that. And for me, I kind of add you into my toolbox of people that I can call on for great information and connections to help with the broader issues that we're working on. So I'm always glad to see you. So the reason why I want to talk to you is that MPHA is working with the Cardinal Health Foundation in collaboration with the 3 schools of pharmacy in Maryland. And we're working on this project focused on optimal prescribing for pain management, really looking at how to reduce the misuse, abuse, and ultimately, deaths related to opioids. And I know just from your work, seeing you around, word of mouth, and whenever we talk about these projects, someone says, "Have you called Neil?" So here we are, we're talking, and really wanted to see sort of what you do in your pharmacies. Why do people always say, "Have you talked to Neil?" whenever these topics come up? So kind of share there, and I have some follow-up that I want to talk to you about how we can expand and spread some of the work that you're doing.
So I appreciate that. And, thanks for having me today. It's a real honor, a privilege to speak with you. And I will also recognize just all the work that you've done for pharmacists, across Maryland from all different areas of our practice. I think when you're out maybe 20 years, I think early on in my career, I was focusing on dispensing and learning how to become a pharmacist and a lot of the things on the day-to-day. And I think the normal maturation of a career, I think you start to get interested to see, how things are working behind the scenes. And so you may see me at a board of pharmacy meeting, or you may see me in an advocacy role at the legislature. You may see me You know, I know we've done some events, you know, with regard to opioids and spreading awareness. So I think when I got towards the middle of my career, I got to be more interested in some of the inner workings and the powers that be, and why things are the way they are. And so I'm curious by nature. And I think I've always been very optimistic and a positive person. And so I want to, you know, I hear sometimes, I know pharmacy can be frustrating for pharmacists and in certain areas of our profession. And so I've always told, you know, my people, like, let's not complain about things. Let's see how things are working and just try to make them better. And so maybe I'm idyllic also by nature, but I want to try to educate myself and make things better where I can. And also it keeps it interesting for me. You know, I'm also a day-to-day pharmacist. I'm still on the bench. I still practice. I'm primarily in Arnold Pharmacy, but I'm in Anne Arundel County with my pharmacies, and I still love it. But one of the things that contributes to me still loving it is seeing the other aspects of pharmacy and how things are being done at different levels. That keeps it interesting for me.
Okay. And so and specifically related to the opioid issue, what are some of the activities that you have in your pharmacies, and how you connect with community?
Well, probably the one reason why, Aaliyah, you and I have crossed paths is, you know, these things happen organically sometimes, but in Anne Arundel County, one of my pharmacies was tasked to provide medicine for basically people in opioid recovery, addiction recovery, and treatment. And, you know, a lot of buprenorphine treatment, you know, et cetera. And because we were participating in supporting those treatment centers, I think I became, you know, curious as to, you know, what's going on, what are the driving factors in the county and in the state and across the nation. And, you know, we want to be a part of the solution. You've heard me comment on pharmacists' role in the opioid epidemic. We definitely, I like to use the word complicit at a minimum. You've probably heard me say that. And so I think my career kind of spanned. I came in the late 90s, and then here we are in 21. So it's really spanned. Really, when I came in, it really wasn't too big of an issue. And then around the middle, things started to really kick off. And then in the teens, you know, things came to an head, and now we're still grappling with those issues. And so it's just like, it's mirrored my career. And I think all pharmacists that are participating in patient care and dispensing, it's a huge issue for us. We face it every day. So, you know, being curious by sort, I just want to try to see what I can do to be part of the solution, you know.
Okay. And so that's for you. Now, how do you incorporate this work with your staff? Because like you said, you know, a lot of pharmacy staff are feeling a bit overwhelmed in some capacity. I think that's a whole other PBM issue, I know, with underpayments and everything. We could go for hours on that. But how do you incorporate your staff into one of your kind of mission areas and community engagement?
It's multifaceted. And, you know, it can be something as simple as training your technicians and talk to them about Narcan and naloxone, and making sure that when you're filling those prescriptions, that there's a Narcan on file, and really pressing forward with the Narcan issue. Even in instances where patients may not want to have a Narcan in their possession, it's multifaceted. So we do try to increase our Narcan dispensing and education. On the day-to-day at Arnold Professional Pharmacy, we take care of many patients in Anne Arundel County that are in treatment. You know, it's really important, I think, to make sure that me as the leader of my pharmacy, that my pharmacy managers, my staff pharmacists, my technicians, that everyone is on the same page with regard to how we're going to approach opioid prescription filling, you know, how we're going to handle prior authorizations, how we're going to interact with physicians. We're going to keep it professional. We're going to hold our own and hold our ground, and we're going to communicate very clearly. We're going to document. And so, you know, a lot of things are occurring in the day-to-day that are just very important approaches that kind of start from the top. But I think educating all of your staff members on how to handle opioid dispensing and education is it's vital.
Okay. And you mentioned, as you're talking about that, in the communications with the physicians and with other providers, how does that go? So we've been engaging with some of the other healthcare provider organizations, and some of the feedback we get, why is pharmacist bothering me? Like, I gave them the prescription, just fill it. And,
Sure.
you know, and we've done some educating for them to say, hey, you got to, you know, there's a professional responsibility on both sides. And so the pharmacist is engaged in patient care and wants to ensure the best outcomes. And so that's what this conversation is about. And in additional conversations, we've also talked about sort of the mutual advocacy for the patient. So could you talk a little bit about how you and your staff engage with physicians if there are concerns about an opioid prescription?
Sure. You know, you're making a lot of excellent points. I think also too, I think historically things have changed. So again, I'll just kind of harken back to the beginning of my career. It would be doctor's orders. So if the doctor wrote it, it would be rare for you to say, hey, this is oxycodone 30 milligrams, 120 tablets every month. So say early on 2000s, part of our training, I think, was, hey, you're here to dispense the physician's orders, and, you know, just keep your head down and do what you're told. And that's not in a negative sense. We were there really to be a part of the team. But as things evolved, I think we began to see that in some instances, there were pharmacists that weren't doing what they were supposed to, and maybe physicians that weren't doing what they were supposed to in the best interest of the patient. And so you would see bad patient outcomes. Obviously, we saw people becoming, you know, they'll come to the pharmacy with more drug-seeking behavior. And so there were negative things that were occurring by the way that we were doing business. Normal status quo had failed us. And so I think that, you know, you get in 2010, 2000 into the teens, you can really see that the chickens had kind of come home to roost. You had physicians that were, you know, and the majority of physicians are so bright and they love their patients, but there was a few bad apples, I think, and that started to get bad press. And I think the paradigm changed for pharmacists to start to say, hey, you know, I'm not comfortable doing this. I'm not gonna just, you know, be complicit and dispense prescriptions when maybe in the back of my head I was saying, you know, maybe this isn't the best thing for the patient. So, you know, and then to fast forward in the last few years, things have gotten much more collaborative because the physician needs us and we need the physician to kind of make things go smoothly. Sometimes it might be wearing the police hat where you have to say, hey, this patient is, you know, out of bounds, doc, and I know you're having kind of trouble with them and keeping them on track and keeping them honest. And they like to hear that feedback. Oh, that's what the patient is doing, and vice versa. You know, the one thing that the opioid epidemic has done, I think it has empowered pharmacists to have more of a voice in patient care. just because the old system obviously was not the way to do things. We could not stand quietly by and fill prescriptions without raising our voice and saying, hey, this is a real patient care issue, and this is not in the best interest of the patient. And so through a lot of mistakes that were made on both sides, pharmacy, medicine, all practitioners, I think that what's coming out on the other end is that I have a heightened sense of collaboration. I will write letters to physicians and say, hey, this person is clearly, they're not on, what's recommended. It's becoming a problem. They're at the pharmacy early every month. And the physician, they don't see that. They write the prescriptions, and appointments don't always line up with, a 30-day cycle. And so those prescriptions may be on file, but I've found that physicians, in a sense of collaboration, they do want to have feedback about how things are going with their patients. Now, you need to be smart about the way you do things. I find oftentimes the telephone has become, less efficient these days. So I do like to write my synopsis letters to physicians in pain management. I always tell my staff pharmacists, look, if there's an issue, you have to document it. It's documentation or it didn't happen. And both sides are incredibly busy. So with e-prescribing and text messaging, there's just a lot of avenues for quick information these days. And I know personally, I've used everything that I can. Now, I'm in a community, I've been there 15 years now at my primary place of practice. Mm-hmm. And so I feel like I have that rapport with my practitioners. And if I'm calling or if I'm making a written request, then they will take it seriously. And I think something in writing always has that gravitas too. Like, oh, this is going to go into the patient chart. The pharmacist has taken time to write basically a care note to say this person's in early, or we have to look at their regimen because, something's not working, or the patient's not owning up to their patient responsibility. And that's also something that physicians know is an issue. And they like to converse with pharmacists about patient responsibility and what we can do to make sure that things are being prescribed, dispensed, and taken appropriately. So those are a few things that come to mind.
There's so much I want to follow up on what you were just talking about. So one thing, when you talk about the patient responsibility, and it's a threefold piece. It's the pharmacist, the patient, and the prescriber. And you can argue who goes where in that mix, but I think it's really just a continuum. And part of our project with Cardinal Health Foundation is this emphasis on I assess, monitor, and manage. And that's the pharmacist, the prescriber, and the patient, everyone kind of taking a look and playing a role in that, the management of pain. And so we do have a pledge, which I'll talk about later. And it's a social media campaign, but in the resources that we've provided on our website, there's an opportunity to just add your name and sort of what your practice setting is, and that you commit to being engaged in this process. So I hope you'll go visit it and sign on to the pledge. But I think that's great. Then also, as you were talking, in some of the conversations you've had with other pharmacists on this topic, they have mentioned, and you've demonstrated, that this type of work takes effort and a commitment. It's not something where you can just say, okay, patient, I have concerns about this, and like you kind of check the mark and done your job. But there's additional effort that has to take place. And I don't know that people really recognize that, like how much work it takes to really make change. And as you were talking about that, then I was also thinking about the Netflix movie, the Pharmacist. And that's sort of an extraordinary story.
It is, yeah.
And outreach. But I wonder, like, in your time where you said you did take more notice sort of in the last, I guess, 10, 15 years on this topic, did you run into a situation where you were able to identify some physicians that were really out of bounds? And
oh yeah, for sure, for sure. I think
you...
all of the all of our listeners, I think this is primarily a pharmacist centric listening audience, and I know if they work in the community, we know who the bad actors were. You know, I think in the Annapolis area, I think that it got, I think, you know, it got to a point where, in speaking to my pharmacists at work chain and other independents, like, we knew to be circumspect about prescriptions that came from certain prescribers. And a lot of times our hands were pretty much tied. We would just stop filling those prescriptions. And again, you know, not necessarily the best answer, because meanwhile, we've got this opioid crisis with recreational drugs, you know, just exploding. And so when you have people that are on, you know, MMEs that are, you know, far exceed 90 per day, and then they are not able to get their prescriptions filled anymore, I mean, it doesn't take a rocket scientist to know that they're going to go to street drugs. And so there have been physicians that are just so completely out of bounds that, you know, that you just know, and you get to a point where you don't fill things. I think I really don't see that anymore. I think the powers that be, federal government, has kind of snuffed those people out where I'm at, and it's such a hot button issue that I think a lot of that has gone away. I think it's more tricky to kind of identify those physicians that, you know, they go right up to the line without going over it. And I think, like, collaboration with them on patient specific information is important. It's, you know, in the pharmacy interaction, like, we don't do patient assessment, and we don't have a great history of what the patient has gone through. And so, you know, treatment of pain and pain management, that's real. And so we don't want to also have an overcorrection where, you know, it's a witch hunt. And so I'm a pharmacist that dispenses pain medicine historically, but it definitely has to be within context. And so you were asking about how do you handle those physicians, you know? I handle them with respect and regard, because they're doing a lot to try and take care of patients with us. And so I always try to collaborate with them, unless they're just completely out of bounds. You know?
Okay. And that brought up something. I was on LinkedIn, and one of the pharmacy associations was sharing a policy that they had, I guess it came out of their House of Delegates, about putting diagnostic codes or information on prescriptions. And we went back and looked at MPHA policies, and we had them. We had one, I guess it got archived. So we're having a discussion about whether it should be pulled out more to the fore. Would that be helpful? Does it make a difference?
I think so. I think there is a disconnect with pharmacists, and we see the patients a lot, don't get me wrong, but a lot of times the discussion may not be that personal in a retail or community setting, like, hey, what's that diagnosis again? Or, you know, tell me about your history. Those things are delicately examined and talked about, and there's HIPAA considerations. And I think pharmacists overall, if I had to predict, I think diagnostic codes, or just something that gives the history. We always need more information to make better decisions. Right. I think you make better decisions. So I don't know what the opponents of that are saying. But I think from a pharmacist perspective, just off the top of my head, I would be all for diagnostic codes to come over as part of the electronic record.
Okay. We're kind of like a heads up, like it gives context.
Context is so important. And I think actually inception points of pain management or opioids are so important, because a lot of times you may have a patient that's 2, 5, 10, 15 years out from whatever happened. And now we're so far down the line, we have forgotten that the patient was in a, horrible automobile accident. And, we don't know all that history. So I think I'm always careful with my staff. Say, we're not in the judgment game here. We're going to make our best clinical decision and, people's pain. And, that being said, there's a lot of malingerers out there. And it's the art of being a pharmacist in the day-to-day of opioid dispensing is trying to suss out quietly who is legit and who is not. I mean, these are things that you're thinking about, but we don't have an examination room and we don't have this history. So I know that the community pharmacists out there are probably nodding their heads saying, yeah, I mean, that's the whole, it becomes almost an art form to say, yeah, like I kind of get where that person's coming from and I want to help them in their care, or yeah, there's something about that patient I'm not 100% certain about. So let's talk to the physician about it. Let's get something on record. It's just, it's tough to know, but any type of history or coding that goes on to hard copies, I'd be all for that.
Okay. Yeah. And as you're talking, it's a balance between, again, you're advocating for the patient, right? But then also there's a balance in how you communicate and how you engage, because you don't want to get into an issue with stigma and like you said, like with judgment. And someone said to me one time that they don't judge, they don't own heaven or hell, so
that's right.
Who are they to
that
say?
Is correct,
but it's a balance, because you don't want to push people away, because you are trying to help. So you don't want that kind of a negative stigma on the patient. So it is an art.
And to follow up on that, Aaliyah, the one thing today when I thought about my comments is like, one thing I hear when I speak privately with pharmacists, one thing that that you don't hear a lot of in the opioid crisis epidemic, it's terrible. But one thing as pharmacists that we need to handle and communicate very directly is patient responsibility. I'm not harping on it, but a lot of time there has been, the focus on the healthcare components of it. Look, I think physicians, pharmacists, acute care places, pain clinics, on the whole, a lot of people have been absolutely failed. They've been duped. And so I'll preface my statements with, like, it's been hard to watch people be taken advantage of by healthcare practitioners, or so to speak. But now that we know so much and things have evolved, I think it is so important to have real talk with patients right up front. I had a patient come in last week. Mom was in for a 16-year-old, and she was getting adenoids done and tonsils. So we're getting liquid Lortab. And we hit a hard halt on day supply based on insurance company. That's a good tool that they use. It's annoying for pharmacists, but it helps us because it opens that dialogue. So I told Mom, insurance only pay for, 3 days dosing, and the doctor wrote for 7. But it was a good opportunity for me to have a real talk about Mom's responsibility to her daughter and her daughter's responsibility. That will be her first opioid as a young adult coming up. And so we've heard so many stories now of people that the girl plays field hockey and blows out her knee, and they give her Vicodin, and then 4 years later, she's on heroin. And so, I would urge pharmacists out there to address patient responsibility, but do take the time to communicate it in a way that is caring and is succinct and is direct, and just say, look, this is not a mystery anymore. We know that if you start dabbling or using these things, you will not be stronger than the opioid addiction. You will not be. And so I just think there's every day in the pharmacy, there's just so many opportunities for pharmacists to say, hey, I noticed that you're on tramadol for the last 6 months, and now your doctor wants you to go to hydrocodone. That this is now becoming a slippery slope. We need to talk alternatives. This is not a place where you want to be.
Mm-hmm.
And so patient responsibility and discussing things with them so that they understand that this is no joke anymore, and this is not a mystery anymore. We've been through, in the last 10 years, it's been it's horrific.
Mm-hmm.
And so just real talk, straight talk, bringing the patients into the fold. This isn't just a doctor, pharmacist, like we're behind the scenes and we're going to give them Nucynta, which they don't know what that is, right? Because, the manufacturers have gotten intelligent about the things that they name, and it makes it tough for the patient at times. But patient responsibility, we have to bring that triad together so that those discussions are occurring.
Okay. And I like that. So for the message to the pharmacy community is kind of, you see that opening, take it. Because
you have to.
You mentioned.
I work chain. I know, there's pharmacists out there that are in community. I work chain half my career, 10 years chain pharmacy, 12 years now, independent. And so I get it. There are so many constraints on time. It's really, really tough. That's why I use the word succinct. Get out there, talk to the patient, be direct, be caring, don't judge, but just say, hey, we're going to have you be an advocate for yourself. You can't be in a week early on your prescription refill every time. You're not advocating for yourself. And so I'm going to advocate for you, and I'm going to move you to, you won't be able to get your prescription filled until 28 days out of 30. And what I do once we get there is I give the patient their next fill date, and in no uncertain terms that April 24th, that's the next time you can get it. And so they know that they need to behave themselves. And we don't have to treat patients that way with so much rigor, but we all, I think pharmacists out there, we kind of see the patients that really need to have rigor and rigidity to their prescription fills, or we're not doing them a service. If every time it's 23 days early and the insurance allows it to go through. And so, but bringing the patient into that conversation in a looking forward or a prospective, talking to the patient, like, I'm looking forward to your next fill, it's going to be this date. Because retrospective doesn't work in opioid prescription filling. Like, that's where you get into your arguments, and that's where things get heated, and that's where things are judgment, and the pharmacist is shuts down because they're frustrated. So I try to take a prospective approach and say, hey, your next fill date's this, I love you, but don't come in before the 28 out of 30 days, or whatever time frame we set up. And that really comes from a place of caring for the patient, because we're not doing them a service when we're filling things early just because we know them, or they say they're traveling, and et cetera, et cetera. And so I just think being very clear and being reminding the patient that they're their biggest advocate is really critical to this process,
Okay. Well, thank you. We have covered a lot, and I was really happy to talk to you, because I think a number of pharmacists are going to pick up some tidbits from this conversation, and we're sharing this message also with our physician community so that they understand where the pharmacist is coming from. So I think we'll wrap it here, but usually how I close is to ask my interviewee about their wellness. So we talk a lot about this right now within the pharmacy community, really just everywhere, about self-care and that sort of thing. So if you could just share with us what you do for wellness. How do you kind of take care of yourself? You're running a bunch of businesses. You said you're still on the bench, you're doing a lot in the community. What do you do to kind of to bring it back to center?
Well, I'm in the gym 3 days a week, and I had a kind of a bad back myself, and never wanted medicine, so started out with physical therapy, and so that kind of, a few years ago, I've been a retail pharmacist on my feet for 23 years. It's tough. Hours are long. I still do 10 to 12 hours a day. Lord knows we don't eat well, and we don't usually get enough exercise because we feel like, well, we're on our feet and we're moving around. And so, but so for me, I've really found a lot of peace in just trying to stay healthy and fit, and doing the things that I like. I love to fish, and I love to be crabbing on the Chesapeake, and those are things that if I have a day off, those contribute to my wellness. I know a lot of pharmacists like to travel. The last year has been very tough because we in the community pharmacy, we will maybe vacation every 3 or 6 months just to kind of unplug and try to recharge, because it is high energy and it is high pressure. And that's been really tough. So I think 2020 has been very tough because some of those outlets have been taken from us.
Right.
And so I'll be looking forward to those things coming back. But for me, I just try to stay active and stay fit.
Okay. All right, good. I'm glad to hear it. I was going to take you for a runner, so I wasn't sure what your answer was going to be. So, but that's cool. So we will go ahead and wrap up. But if you wanted to take a look at the work and the businesses of Neil, his website is professionalpharmacygroup.com, and you can find him on LinkedIn at Neil Patrick McGarvey. So with that, we'll go ahead and close. And thank you so much. It was a great conversation.
It was just an absolute pleasure to be with you, Aaliyah. And thanks for all you do for us.
No problem. I love it. Thanks.
All right.
Thanks for watching. And please be sure to like, subscribe, and rate the podcast on all major podcast platforms. We look forward to dropping more great conversations. And of course, sponsorship opportunities are available. Just contact us at MPHA. Thanks.